Diagnosis is a process of finding out if a patient has a specific disease. However, the following should be kept in mind. Most diagnostic information is imperfect and should not assume. Uncertainty is unavoidable. A test should be ordered only when it could lead to a change in patient management. Some methods to diagnose acute kidney injury is measured by the rise of serotonin creatinine, the decline of urine output, CT scan, renal biopsy, or ultrasound. Kidney disease improving global outcome defines the requirement of an AKI, as well as the Rifle criteria which classifies the severity. Kittigate's definition of AKI is the increase of creatinine by more than 0.3 mg per deciliter within 48 hours, or more than 1.5 times the baseline of creatinine filtered. Rifle criteria classifies AKI into risk, where the serum creatinine is increased by 1.5, injury, where it is increased by 2 times, failure, where it's 3 times the baseline, the complete loss of kidney functions for more than 4 weeks, or the complete loss of kidney functions for more than 3 months. Serum creatinine is produced when using anaerobic respiration for muscle contractions. It is an end product of muscle metabolism and could take up to 36 hours for it to rise. Weight-based urine output calculations are misleading, as this can provide an abnormal amount of output required by an obese patient. It also requires a baseline function, meaning previous test results has to be compared. Serum creatinine is a marker of excretory functions and does not provide any information on other roles of kidney. It does not get fully filtered, as well as age, weight, gender affects the amount of urine output and serum creatinine in the blood. The AKQI suggests utilizing new biomarkers such as cystatin C. Cystatin C is a large molecule that is fully catabolized after filtration, then fully absorbed into the tubules, not reabsorbed into the blood. Cystatin C rises sooner than serum creatinine, that's a better indicator for AKI. Further testing may be required to determine underlying causes. Imaging techniques are used to identify the anatomical structure and injuries of the kidney. A CT scan creates detailed pictures of the body identifying lesions, masses, obstructions, and vascular abnormalities, often used as follow-up. Renal biopsy is where a small piece of kidney tissue is removed from the body for examination, usually under a microscope. It is the best method for identifying intrarenal causes such as glomerulorenal disease. Ultrasound creates images of soft tissue structures and detect blockages without exposure to nephrotoxic contrast agents, showing potential abnormalities in kidney flow, tubular functions, and the collecting systems. These imaging techniques are non-invasive and accessible for diagnosis as well as follow-up care. However, training is required to interpret the information. Fast and efficient diagnoses are essential for early management and a timely intervention. This can ultimately reduce the risk of complications, reduce stays in hospital, and mortality rates of AKI.